Thank Kenyatta National. I want to thank Kenyatta National Hospital for giving us this opportunity to talk about dementia. As I said, my name is Dr. Zipporah Ali. My background is public health and palliative care. And we really thought of bringing this topic on board because we get a lot of questions, a lot of concerns on how to, deal with dementia patients, especially from family members, and even healthcare providers find this as a challenge because sometimes we misdiagnose our patients. We know places where they're referred to as mad people, they are tied up or even burned as witches. So really, we thought maybe it's just good to do some sensitization on what dementia is, and then also we'll actually hear from an expert, and then we'll also hear from a caregiver. So I'll introduce the speakers. Our first speaker will be Dr. Christine Musime. She's a PhD researcher and the head of Research, Ethics and Scientific Publications Department at Africa Mental Health Research and Training Foundation. Her research focuses on promoting excellence in community-based mental health research and developing innovative strategies with special attention to depression, dementia, intimate partner violence, and intimate partner violence. Dr. Msumi has been the principal investigator for several projects aimed at training traditional and faith healers to deliver evidence-based mental health care in community settings. She has also been a research fellow on the multi-country to strengthening response to dementia in developing countries, a project called STRIDE that will contribute to the development of the National Dementia Plan in Kenya. So she'll be our first speaker, and I'll introduce the next speaker so that we don't have a break in between. Our next speaker is Elizabeth Mutunga. She's a trained psychologist and human rights practitioner. She developed an interest in Alzheimer's disease after her father was diagnosed in 2007. At the time, the disease was a mystery to her and her family. And in trying to understand how best to cope with the disease and care for her father, she started looking for support group which she could plug into and get support, encouragement, and work with the other caregivers. When she found no support groups, she decided to start a monthly support group herself. Due to her passion to help others affected by the disease, she decided to start an NGO called Alzheimer's Dementia Organizations Kenya. And I really want to say that I admire Elizabeth's work. She has shared her story with many of us before, when her father had dementia when she was very, very young, and she had to become the father in the family. So I'm sure we'll also be very happy to hear from a caregiver through the experience. So welcome speakers, and thank you again once more, Kenyatta National Hospital, and thank you for all participants who are taking time to attend this session. We hope we'll have a very good session, interactive, and a time for questions and answers. Please type your questions in the Q&A session. Any discussion that maybe you want to contribute, also you can type in the chat, and you can write your name and your place of work or your background briefly on the chat so that we can know who is attending this session. Thank you very much. Dr. Msimi, over to you.
Sorry, thank you so much, Dr. Zipporah, for that elaborate description, and I look forward to having discussions with the team, either on the chat or live discussions, because this is live streaming. So I'm going to share my screen because I'll be talking for the next 30 to 45 minutes. Let me just, can you see my screen?
Yes, we can see your screen.
Wonderful. So I'm presenting this on behalf of Professor David Dete, who is a psychiatrist and at the University of Nairobi, as well as a professor of psychiatry, and as well as practicing psychiatry in Kenya. So just to start off the discussion, maybe it is important for us to know what dementia is from the way people interpret it, because there are different cadres in this. We have probably nurses, we have doctors, we have clinical officers, we have different professionals in this setting. And so I'll try to make this presentation as simple as possible, while making sure that we use terms that are recognized scientifically as well as in academia. So maybe as you look at the slide, I want us maybe in 2 seconds or a minute to share what do people say dementia is, what do they say is the cause of dementia. And you can have that in mind as you can also put it on the chat, and I'll be able to read that out. I've tried to stop the presentation so that I can see people typing, and this is just to make sure that the almost 500 people are still listening and are ready to understand what dementia is, because sometimes it's what people say that makes us, you know, question what dementia is. And I've seen an anonymous attendee say, dementia is age. I like that. And most people think that, you know, once you have dementia, you're just aging. Then thank you for sharing that on the chat. Anyone else would like to post something on what dementia is? What comes to your mind when you hear dementia? What comes to your mind when you hear the causes of dementia? And we'll be able to know why people say dementia. Peter Kaigunya says some people say dementia is due to being too active, you exhausting your mind, and I'll be sharing that in a couple of slides. Thank you, Peter Kaigunya. I see a number of comments coming in. It's alcohol, it's degeneration, slow working of the brain, and it's confusion. Thank you, everyone, for those kind of. I've seen senile degeneration. I've seen old age, split of mind, and this is referred to as loss of network. Thank you, and just having that those comments is important for us so that you can be able to have an idea. Sorry about that. To have an idea of what dementia is. Can you see my screen?
Yes, we can see it.
Is it in presentation mode?
No, it's not in operation. It was before, but now it's not. Okay, fine now.
About now. Great.
It's okay.
Thank you, thank you. So I just pose this question so that we can think through what dementia is. Sometimes we know the causes, but it's also important to understand what the community views dementia. So thank you very much for those that have shared on the chat, and for those that are still thinking, which will form the basis. Your discussions or your thoughts will form the basis of our discussions today. And I'm going to present some literature on what the community views. And this was a sample of a small population, community members, ranging from carers of people living with dementia, ranging from, you know, to healthcare professionals, community health volunteers, and even members of the general public from different professions. So when we interviewed through a questionnaire, 59 members of the general public, 82% of the respondents mentioned that dementia is in part due to normal aging. So once you have dementia, it's because you're aged, that's it. So imagine it's almost 9 out of every 10. So only 1 to 2 people knew that dementia is not partly due to normal aging. If you go to the second statement, it says that 55% of the respondents mentioned that dementia is caused in part due to lack of family support. And I'm saying this because this is not usually the case. So these are just beliefs, attitudes, misconceptions. So if a person is not taking care of a family, then half of the people will believe that it's because the person has dementia because they did not get good family support, good parenting, and all that. And then 62% of respondents believe that nothing can be done to prevent dementia. Or they do not know if dementia is preventable. And that's why they believe, you realize that 74% say that dementia is more often than not. People living with dementia are dangerous more often than not. And they pose a risk to their neighbors, and that's why they need to be kept in a hospital or in a nursing home. And I'm sure because most of us are healthcare workers, we can attest that, you know, the hospital sometimes is a dumping site, if I would say, because someone will come and put in the person living with dementia there, and they go back to their homes. And then all the work will be left to the healthcare professionals to see what to do. So sometimes we are able to manage the condition, or we are not able to, and sometimes it becomes very, very difficult. So I think the purpose of this, one of the reasons why we are having this discussion, is to be able to understand how to educate the community. It's not just about the diagnosis, it's not just about understanding the causative factors, but also how we can manage in terms of psychoeducation that I'll be sharing in a couple of slides. 90% of respondents also believe that people living with dementia do not understand simple instructions. That's almost 100%. 9 out of every 10 people believe that people living with dementia cannot understand a simple instruction as, go to the market and do this. And this is because dementia in Kenya is usually detected at very late stages. So if you're not able to detect dementia at very early stages, and when the disease progresses, then we realize that people living with dementia at advanced stages, they might not understand simple instructions because their functioning has been affected, their cognitive functioning, their language has been affected. And then 82% of respondents believe that people living with dementia make people around them uncomfortable. And again, detection of dementia at advanced stages in Kenya is happening, making, and once you detect dementia at advanced stages, so sometimes your behavior is affected, the pattern, the way you reason or pattern of thinking is affected. And so that's why people believe that people living with dementia make people uncomfortable, because detection is not done at very, very early stages. And then 74% of people believe that people living with dementia are not able to make meaningful decisions, again, because of late detection of dementia. And finally, 65%, this is now related to us. 65% of respondents believe that people living with dementia should be worried about discrimination by doctors unwilling to provide treatment. So, and that's why in this discussion, I thought of structuring, the presentation in such a way that we address this 65% perception of people, where they are worried. Yes, they might want to come for treatment. They might want to come to the hospital to receive a diagnosis, but again, they are worried about discrimination by doctors. So, what can we do about it? So again, something else that contributes to people not accessing care, apart from what we just talked about, stigma, we have, I would just want to elaborate more on the specific aspects where dementia is considered normal part of the aging process. And these are based on qualitative interviews that we had done with members in one of the counties in Ukambani, whereby perception of the condition was considered to be affecting old people. And we need to understand that dementia is not a disease of the old. It is just that age is a risk factor, and it actually doubles after the age of 65. The prevalence doubles after the age of 65, but it doesn't mean that everyone who is old and tends to have some decline in cognitive function then has dementia. So, once you get old, you'll get dementia. So that's something for us to be able to understand at the end of this discussion. Doctors don't call it a disease. These are statements from community members. They are saying, doctors don't call it a disease. They're assuming that it is a normal situation in old age that does not require treatment. These are not my words, but people from the community. We had someone say that dementia, when someone has dementia, she just suffers from old age. Just dementia, because dementia is old age. And then just going specific into the specific terms that are used for dementia. And that's why in the current DSM-5 classification, we have dementia being used as major neurocognitive disorder, because the term dementia is used negatively across cultures. In Kenya specifically, we have in Ukambani, the term dementia is called thingai. Sure, we have a number of Kambas in this presentation, and thingai originated from the term thinking high. So you can tell thingai, if you say thinking high, is just thingai, someone saying, so the original word was actually thinking high, but how it came about is because, community members assume that people that were in formal employment, like all of us, most of us, they retire and then they go back to the rural areas. And once they develop dementia, then they are told they were thinking high when they were in formal settings, they were in formal employment, and now that they have come back to the rural area, that's why they have developed dementia. They thought they were good, that's what they were thinking, and that's how dementia has been used. So it means it has a negative connotation. It's also an accept. People feel that it is being abusive. Once I have retired and I have dementia, why do you want to tell me that I was thinking high? It's also used as a joke. For example, I'm going to use a Swahili term. I'm not sure if everyone understands Swahili this presentation, but someone will say, kwani uko na dementia, kwani uko na thinga, So people use it as a joke, just because you have forgotten something, as a wallet or your phone. Someone you use it jokingly, not knowing that the person whom you're talking to could actually be having dementia. So it's also used, someone said it's like a dog's name. And this is coming from the perspective that dogs have worse characters than cats. Now, this is someone or community members looking at the perspective of the behavioral aspect of someone with dementia, because when the behavior change, people assume that it is character issue. It is someone that needs to change their habit or their character, and that's why they're saying that dogs have what characters than issues. So someone living with dementia is behaving like a dog. That's why the dog is coming up. The dog's name is coming up. So it means the dog character is not the fact that dementia it feels like a dog's name. People don't want to use it in the local setting. In terms of, this is a big deal in terms of supernatural attribution. Look at theme 3, where people say that she had been bewitched. That's why she has dementia, or he has dementia, or he got addicted to books. And these are excerpts from statements. And I've seen that from some of the charts where someone got addicted to books while in school. And that's why we have some of these statements that alisoma sana, or, she's went to school for, she's read a lot, and that's why he or she has dementia. And then it's assumed that there's a demon possession. And then, for example, if someone was married and the spouse passed on and they left their matrimonial home, then it means, and unfortunately they developed dementia, then they are assumed to have developed dementia because they left their matrimonial home after the death of a spouse. And finally, in community settings, it is assumed that dementia is a disease that cannot be treated. So, or it's not a disease that can be treated. So maybe some of us are asking ourselves, can it be treated anyway? We'll be able to figure out that. But one statement I will need to say now is that dementia has no cure, but it can be managed. Dementia disease is the most dangerous disease ever in the community. That's what people people feel in the community, that it's the most dangerous disease, because no one tells that, people don't know the cause. And then they use very sensitive words like, a person living with dementia is just waiting to die, which becomes a little tricky. So I'm going to jump into the healthcare worker stigma, so that we know that we've learned that this kind of stigma comes from the community. But we also want us to show ourselves, or to be able to see that stigma can also originate from healthcare professionals. We have a carer from our discussions who said, the doctor told me at old age, brain issues arise, so this is normal. That is someone who has a person living with dementia, and they're saying what happened when they went to the hospital. And by a doctor, I don't mean apologies for doctors that are here by title, or I mean nurses, I mean clinical officers, anyone who is working in a healthcare setting. Most people in the community settings refer to anyone in the clinic or in the primary healthcare setting a doctor. So I'm not referring to doctors by medical officers, or I'm referring to anyone who is working in the clinical setting. And then a healthcare worker, this is a perspective from a healthcare worker now saying that Dementia is usually a condition that is not actively investigated or treated, depending on the social status of the patient. Some of the persons living with dementia will probably be told that there is a drug that will help improve their symptoms. But for the extreme ages, after 80 or 90, one talks to their relatives and tells them, this comes with age and there's nothing much you can do about it. That stigma right there. Then we have a carer saying that nobody cares about people living with dementia. It's all been left to us carers to take care of our people. So they feel neglected. And then another healthcare worker said that so this is a carer who had received a diagnosis from the hospital. And so she's just saying that, I'm not happy with how the process went. And she said, I once inquired because I wanted to know what the prescription I got was supposed to treat. So she has received a prescription, but she doesn't know, she wants more information on the medication that the person has been given. So I got curious because laboratory results didn't show any sickness I had. From the laboratory, I was sent to a different room to collect my prescription. I asked what the medicines were for and what I suffered from. From my observation, I simply thought the doctor, again, the doctor, I mean healthcare professional or healthcare worker, I simply thought the doctor was tired and overwhelmed by the number of patients that were waiting to be seen. He rebuked me and I left the room. He didn't seem to have time to explain to me the purpose of the medicine. I was hurt, did not buy the medicine, and simply went home. So that tells, and this is not just about dementia, it's basically how we see our patients in the hospital. For more quotes, more excerpts, feel free to access that article that is published in Dementia Journal on perceptions and experiences of dementia and its care in rural Kenya. So now let's come to what dementia is. We have been discussing for the past few minutes on, perceptions, attributions of dementia, what are the causes based on the community perspectives, based on the healthcare work perspectives. And these are basically myths or beliefs based on individuals. So I want us now to look at what dementia in reality is. So it's important to acknowledge that dementia is not a single disease. It's an umbrella term, just like heart disease, and it covers a wide range of symptoms or conditions. And the most common is Alzheimer's disease, which accounts for about 60 to 70% of cases. And feel free to read more in that link. Dementia is often, and I want to emphasize this because I have seen in most records, the hospital, lots of senile dementia, like it's basically the entire diagnosis that's being made in most healthcare settings, primary healthcare settings. So we see that it's great. We need to understand that dementia has been referred to as senility, which in English means, something originated from old age. But we know that's not the case. We just know that age is a risk factor. We just know that it is caused by age is one of the biggest risk factors for dementia, but it's not necessarily a diagnosis for dementia. So senile dementia, senility, as reflected in some of our records, even presently, reflects the formerly widespread but incorrect belief that serious mental decline is a normal part of aging, and that is what we are trying to demystify through these conversations. So dementia is a decline in mental ability severe enough to interfere with independence and daily life. So in this slide, I'm going to share more on, a minute, I'm trying to take this so that it's a bit clear. So in this slide, I want us to, it's basically making a diagnosis of dementia. I wanted to just use a standard criteria. There are many tools that can lead us here that have been standardized. We have the 1066 algorithm. These are screening tools, but I thought it's important for us to use what we have used in the past and what we have used and trained in the past. So based on from the DSM-5 criteria, dementia has used the term major neurocognitive disorder. In DSM-4, there was use of dementia, and this changed because the term dementia as I said, has been used in a negative way. It actually relates to a Latin word, which means madness or insane. And so just to reduce that stigma, that's why DSM-5 criteria used major neurocognitive disorder. But you realize for people to understand clearly and better, most healthcare professionals, most organizations are using the term dementia. So that's why I'm using it. It's not yet really, people have not really captured the major neurocognitive disorder. And so that's why I'm still using dementia. And that's something that we are using across various populations. So, sorry, is there someone talking? All right, great. So characteristically, for someone who has dementia, there needs to be evidence of significant decline from a previous level of performance in at least one of the cognitive domains that I'll be discussing before. And by significant cognitive decline, this kind of decline is either reported by the individual who is experiencing the decline. It can either be informed by, by an informant who is knowledgeable, who is known to the person, or can actually be made by a clinician at the hospital or a healthcare worker who can use a standard measure, who can use a specific recognized measure to identify these symptoms. So one of the symptoms that we need to understand, at least one, is learning and memory. Could be short-term memory. Most of us say, and that's why we joke about it, that if I forget my phone, and sometimes we have our phones, I'm sure some of us have this experience, you're talking on phone, and then you're looking for your phone, you're asking for the other person, you know what, I'm trying to get out of the house, but I'm looking for my phone, yet you're talking on phone. We can't say that's dementia. We're talking about repetitive, forgetfulness, where someone forgets a number of occurrences. It could be, you've forgotten what you took in the morning. It could be you forgot what you placed, where you placed your wallet or your purse, and this could be, affect your independent daily activities. And that's why we will say we have cognitive decline, but this decline, at least one of them, needs to be accompanied in part B by interference with independence in everyday activities. And then the second domain is language, where people have difficulties in communicating or there is no cohesion. And then there is executive function, where there is emotional imbalance or self-control. There's, lack of flexible thinking, there's no organized speech and all that. Then there's complex attention, where someone is easily distracted or unable to perform mental calculations. For example, if you ask someone who has actually gone to school, what is 5 + 5, or, try to present something in a coherent way. And then there's perceptual motor, where your motor function is affected, and perceptions, the different perceptions, your eyes, your audio, your different aspects, you're not able to coordinate. And then we have social cognition, whereby there is change in and consciousness of the mental state, and so you're not able to appreciate the social interaction in a more interactive way. So someone tends to get influenced by their feelings or attitude, not because of character defect or deficit, but rather because of an issue with them, effect of the brain being affected. As I mentioned, all these, you just need one of them, but it needs to be accompanied by interference with independence in everyday activities. And then these cognitive deficits do not exclusively occur in the context of a delirium. They can occur, in a different state. And delirium, I mean a state where someone is confused or disoriented for about a few hours or a number of days, or not able to think properly. And then we need to understand that once we have at least one of these cognitive domains, they need not to be explained by another condition. Because, for example, if you look at easily distracted or sadness, which is one of the characteristics of dementia, and still one of the characteristics of depression, and then there's still interference in daily activity. So it's important, once we identify these symptoms, we also rule out other conditions. So what are the causes of dementia? And this is where why it's possible to understand that dementia has no cure, but it has a cause that can actually be reversed. We say dementia is reversible. What we need to say is that, first of all, dementia is caused by damage to brain cells. And dementia causes can either be reversible or irreversible. So we are talking about the causes rather than dementia. So it's once we reverse the causes, then it's possible to say that we have prevented dementia. So there are a number of factors that cause symptoms of dementia. And some of the symptoms, as I talked about, in terms of language, speech, and all that. So it causes change in the brain that may cause either dementia changes that are permanent or worsen over time. And potentially reversible dementia symptoms are caused by depression, stroke, traumatic brain injury, certain medication, and even bladder infections. And if these conditions, we are not able to improve or reverse these conditions or treat them, then that's why people will get dementia that is reversible. And so irreversible progressive dementia, these are now the actual types of dementia. And the most common type, which affects a number of people, is Alzheimer's disease. We have vascular disease, we have Lewy body, we have temporal, and many others. So it's important to acknowledge that the dementia causes are the ones that can be reversed. So I skipped the management section because I wanted us to talk about stigma in a couple of slides, because that will form the basis of our treatment, or rather management of patients. So just to give you a brief, a snapshot of, the available interventions, or, first of all, it's important to understand there is lack of evidence on dementia prevalence, but across the country, but in healthcare settings, we tend to identify dementia as senile dementia. It's important. Once we acknowledge this, we can be able to use the appropriate diagnosis or terms. So a number of RCTs, there was a study that within a project called STRIDE that I was involved for the past 4 years, that assessed the number of interventions that were evaluated on effectiveness on people living with dementia and their carers. And out of the RCTs that were found, there were none in Kenya, RCTs. There were only in Africa. There was one in Tanzania and another one in South Africa. So less than 5 in Africa actually found, these are studies that were tested for effectiveness in terms of intervention. So that tells you there are lots of, there's lack of evidence in terms of what can be done in order to provide for intervention. But of course, WHO or World Health Organization has provided interventions, for example, the MH gap, that will help us to be able to understand what dementia is and also to be able to provide treatment appropriately. So there are a number of gaps that are hindering treatment despite the lack of interventions. We have a stigma, and we just talked about stigma, which is a major issue. And where there is stigma, this results in neglect and abuse, because people will not come to the hospital for care. So that is one of the things that we need to address when it comes to treatment. And then early detection of dementia, diagnosis, it takes between 18 months to 4 years. And this is not just in Kenya, but across the world. So you might realize over time, you're still going to one professional to another. And so it takes a lot of time to be able to understand what dementia is, or if someone has dementia. And then there is a huge strain on health systems, because most of us are not trained on how to identify dementia, or once we are trained, when we go in those healthcare settings, we are not able to apply these skills because maybe there is no that support in daily. It's important to include CMEs on dementia in our healthcare settings. And then most dementia care is predominantly provided by family carers, and there is also no formal care arrangement for people living with dementia. So based on these gaps, stigma being a major contributor to lack of access to care, then we developed, the STRIDE team, we developed an intervention to create awareness first, because if awareness is not created, then people will not come to the hospital. So we use a social contact intervention, which has been known to be among the most effective type intervention to reduce stigma. And by social contact, I mean people sharing their experiences. And this is what we'll be doing in our session today, where Elizabeth will be sharing about her experiences, the journey she's been. And so that is one of the ways to help community members understand what dementia is. And so we incorporated through video because of COVID-19, we use a video-based social contact element to, as one of the sessions, we trained people or community health volunteers who trained community members on what dementia is. I'll be sharing the specific sessions of the 4 sessions in the next slide. So, and it was supposed to be delivered bi-weekly and dedicated to specific topics. So these are basically the specific aspects. We had understanding dementia, where we trained them on signs of and symptoms of dementia, activities that a person living with dementia can perform, the importance of receiving care. And then in session 2, we addressed the common myths and misconceptions. I could see people saying witchcraft in the chat, saying lots of attributions of dementia. So we are trying to understand, or to help the community understand that these are just myths, and it's important for people to access care and use appropriate language rather than thing as we talked about. And then again, the video base where people share their experiences so that we avoid violation of human rights of people living with dementia. And then the last session was on social inclusion of people living with dementia, where we used a case study to try and imagine story, where we illustrated or we shared a story of someone living with dementia and how the community can be able to prevent stigma towards such individuals. And based on our findings, after we trained community health volunteers, one of the members of the general public said, I can relate with people living with dementia and their carers, because it is not their fault. So if you look at the statements before, when we began this presentation, and now, you can tell the discussion is different. It has now changed. And then from a carer of a person living with dementia, he said that previously I had challenges relating with my mother, since I was not allowing her to perform any activities. I have recently learned to be patient, responsive to her needs, and allow her to perform any pleasurable activities at home and provide supervision for activities that need my attention. And we are now relating well. So this is a carer who feels the impact of this intervention. So it's important to understand the importance of also relating with community health volunteers who can be able to make an impact in our communities rather than working individually. So, and as a response to this, as we are creating awareness, we realized most people in the community do not know how to identify dementia. Even the community health volunteers didn't know how to identify dementia. They were saying these are the common symptoms, these are the myths, but one of the gaps that came out during the discussions was, then how do I know that I have dementia? And so we have sought funding and received funding to integrate dementia screening, how to identify dementia in Makueni County through the County Referral Hospital in collaboration with Dr. Joe Masila and the facilitators at the hospital, Makueni County Referral Hospital. And so what we are doing that, because we know dementia screening and diagnosis is not common practice and is not featured within the role of community health volunteers, then we will engage the same community health volunteers whom we trained and a couple others to screen over 2,400 people who are age 60 and above, because these are the risk populations. So that once they know how to screen, then they can be able to continue this as part of their normal practice. So this has not yet begun, but Makueni County Referral Hospital will be the first beneficiary of integration of the screening, dementia screening in Kenya. So now let's come to management. And I put this slide specifically here because I thought it's important for us to understand psychoeducation. Psychoeducation is basically what I have talked about, what dementia is, what are the stigma, because most of the people don't come to the hospital, or the condition worsen because gets worse because of the stigma surrounding the families. So the most important thing is to educate the family, the individual, and the family members, and also manage behavioral and psychological symptoms. For example, you can identify what triggers some of the symptoms, what makes the person to leave the house. Or, some of these triggers can actually be managed based on, customized settings at home. And then you can suggest activities that the person enjoys, for example, walking, so that they are more engaged on activities that are pleasurable rather than forced activities. And then it's important to promote functioning in daily activities. For example, you can do toileting skills. In some cases, hospital, families have put even arrows. For example, if they forget, families have put arrows, or they've indicated things that will actually be a clue on, this is a toilet, this is the kitchen, even putting, labels in each of the doors. And then interventions to improve cognitive functioning, because this can be cognitive stimulation therapy, or using simple sentences to try and engage the person. You can also engage person in reading newspapers or radio and all that. And carers cannot be left out. I mentioned that these are the primary carers, are predominantly main dementia care support system. So it's important to also support them, train them, get the primary carer, and try to educate this person on what dementia is. And then antipsychotic medication, I'm not going to delve into that detail because I know we have different professionals here, and some of professionals are not supposed to prescribe as per the guidelines. So kindly allow me to just leave this here so that, because for details, I'm sure we all have specific glossary or specific books that can lead us to specific management. In conclusion, we are saying that understanding the local interpretation of dementia could help us understand or help us alleviate the negative stereotypes or stigma. And it's also important to empower individuals with dementia and their families to share their experiences, and also using available anti-stigma interventions to reduce stigma can help improve access to care, and stigma reduction can increase early detection of dementia and improve access to care. So these are some of the references. Most of these findings have been borrowed from the STRIDE work that we did. So feel free to access the website on www.stride-dementia.org. For any questions, feel free to contact me and follow us on Twitter. Thank you very much.
Thank you very much, Christine, for that very insightful session. I'm sure the audience have found it engaging. And thank you for really making us understand that we are probably not doing the best we can for these patients who have dementia due to a lot of stigma, cultural issues, and also just because we don't have the right knowledge and understanding of what dementia is. So thank you very much for that wonderful session. I would like now to ask the next speaker, Elizabeth, to start so that we can have the questions and answer session at the end.
Hi, everyone. Can you see my screen?
Yes, we can, Elizabeth. Okay. But can you make it into
presentation?
Yeah, if you can.
Is that better?
Yes, much better.
Okay, all right. Hi, everyone. My name is Elizabeth Mtunga. I'm from the Alzheimer's and Dementia Organization, Kenya, an organization that was formed after learning about Dad's condition. And as Dr. Zippy was introducing me, I went looking for a support group where I could plug in after we were informed that Dad had dementia. That was in the 90s. So a lot of people then did not understand what dementia was. And as Christine has ably said, a lot of people did not know, and still a lot of people still do not understand what it is. And so I just want us to do a quick exercise just for you not to forget what Christine has taught you. So if you have a paper next to you or your phone or something, just write 5 things that you cannot live without. 5 things, and then just write on the chat so that we don't waste a lot of time. We have very few minutes. Just 5 things that you cannot live without. And then I'll tell you what next. So if you can just put maybe thumbs up so that I can know if you're done, so that I can move you to the next session quickly. And don't overthink. Whatever comes in your mind, just put it down. So I'll be looking at the chat to know if you've done it. just write it on a paper, so that, because I need you to also do something on that paper where you're writing it down. Thank you. I can see people cannot do without their phones. Interesting. Money. Okay. Just put it on the paper, 5 things. Are we done with the 5 things? Yes, since somebody who's put the 5. So the next thing you do, I want you to remove 2 that you now think you can live without from that list. And it would be nice to just know from you what you're feeling as I'm telling you to remove the 2 that I think you can live without, and after I'd said you can do without them. You cannot do without them. Are we done with the 2? Have we removed the 2? Yes?
I think we have.
Okay, the next 2, remove 2 more from that list. So once you have removed, I'm seeing others now with just 3. How does it feel? It makes you feel, how can she tell us do that? I mean, how can she make us remove things that we cannot live without? Some things are very difficult. How do I tell you to remove oxygen, for example? How do I tell you to remove family? How do I tell you to remove your phone, for example, or food? But that is what happens to people living with dementia, because they are not asked, what do you want us to remove from your lives? When dementia comes knocking, there's nothing we can do about it. It just comes and it takes away all the things that were very important to you, and they end up going. And so that is what happened to us. And Dad was a policeman, and he had served in the police force for many, many years. And it was quite difficult for him to, I'm trying to move my screen. It was very difficult for him to stop being a policeman, and he got diabetes, and he went into a diabetic coma in around 1985. And after that, being a policeman, he couldn't perform his duties as he would. And so he had to be requested to resign. And so Dad could not cope by being a civilian. And this affected him really badly. And after that, after being retrenched, he lost a daughter my sister who had cancer, and Dad just started declining, and he started doing very strange things. Dad was, as you can see from the photo, he was used to be smartly dressed. I mean, he liked, life. He enjoyed good things in life. And then all of a sudden, Dad is wearing his pajamas on top of his Kaunda suit because he doesn't know what to do. And then now he started moving us from a 4-bedroom maisonette house to a Mabati house around the corner, and you're wondering what happened to him. And so he started doing weird things that normally you wouldn't expect somebody to do. And one of the 2 that were really shocking was when he told my sister, who was going to join Form 1, let me show you her photo. She's the last one on the second photo, or the one who's at the front with a black sweater. So my sister was joining Form 1, and my dad told her that you cannot go to high school because my dad's mental capacity had gone back to the olden days when girls never used to be educated. And so he told her, you have to wait at home until your husband comes for you. And I had just finished Form 4. So for us, we were wondering what happened to him. The second thing that was quite shocking was when he moved us to the Mabati house around the corner, which was quite shocking. And then he's telling us, Jesus is coming, we don't need all these things. And the final thing is when he started selling the car in parts. So he would sell the tires alone and the rest of the body vehicle alone. So Dad started doing things that normally he wouldn't do. So at 17, I had to go and look for work to educate my siblings. My siblings are the ones on the far right. My mom is the one in white. And so I had to go, and my sister was joining Form 1. My brother was in Form 3 then. And so I had to go and look for work so that I could educate them. And so I took them to high school. I took them to, each of them to take a course. But for me, I kept wondering what happened to Dad, because I was not understanding what was going on with him. He couldn't have just changed all of a sudden. And with time, like I said, it was in 1992. In 2007, we finally went to see a doctor who we explained what we were seeing with Dad. And he told us that she told us they think it could be dementia, but we go and read about it ourselves. But from what she knows, there is no cure. So that is how the message about dementia was related to us. And so for me, I was like, what do you mean? So I started researching, and I was doing then my counseling course at Amani. And I decided to write a paper. And even as I was talking to the counselors, a lot of them did not understand what it is. And as I speak also to a lot of medical professionals, a lot of them tell us this was a topic that was just brushed through college. It was not something that was taken time. And it's because a lot of times we all believed, and all the story that was there was dementia is for people living abroad, not Africans. It does not affect Africans. It is just part of aging. So wakizeeka, this is what you see when people start getting old. And so in 2007, when I was doing my paper, that is when I started realizing there's a bigger issue, because you're looking for prevalence. People asking you, what are the numbers in Kenya? Of course, we do not have numbers. And as Christine has rightly said, there's a lot of stigma. So a lot of people will not come out and say my loved one has dementia. And they will tell you that we are, they'll talk about diabetes, blood pressure, or any other thing, but not dementia, because they still, people still are not comfortable to come out and speak about it because of the way these people behave when they are unwell. And so with time, that's not how we knew what dementia was. So I started looking for a support group to plug in. It was not possible, but finally working with South Africa Mental Health with Professor Ndetei, we started an association. And we did it from 2007 to about 2009. My dad rested in 2009. And by then, I think I was just too tired of working about dementia. And I did not want to do anything else, because it was painful to just see dad degenerating, and there's nothing you can do about it. The other time he got lost, and he got onto a ferry and went to the other side of, excuse me, went to the other side of Diani, and then he collapsed. And we thank God that at least he was picked by beach boys and he was taken to a home, cleaned up, and then this lady went to the police to say, but there are many people who will tell us that they have lost their loved ones and they have never seen them again. Another time he got lost, and he knew when I go to the policeman, having been a policeman or to a police station, I'll get the help that I require. And so he would get into went to the police station and told them, I am lost. And the policeman looked at him and asked him, kama unajua umepotea, why don't you just find your way? And you see, because it doesn't make sense. He knows he's lost, and he's coming to tell you he's lost. Then you ask him, what is his name? He couldn't say his name. Thank God, again, we found him walking back to Nairobi. So we are grateful. At least we did not lose dad, but the many opportunities that presented themselves that were scary, were many. The other thing that we also, that was very painful was during my wedding. As I was walking down the aisle, he was to walk me down. And then he said, so I told him, Dad, we need to now get into church. And then he looks at me and asks me, what did you say? I said, we need to walk him. He says, no, I'm not your father. You wait for your father to come for you and take you and walk you down the aisle. And I'm thinking, you chose today to tell me that you're not my father. But for him, in his mind, he'd already gone to his late teens, early 20s. So he didn't have a family. So for me, who was I to tell him that I am his daughter? Another time also I went to visit him, and he starts asking me, so how are your parents? How are they doing? So I'm like, they're fine. Then initially I was like, what is he talking about? When I looked at him, I said, but you're my dad. He says, no, I'm not. Then he started crying and asking, how can I forget my own child? So from then on, I changed my narrative. Of course, it was painful. There are very, many times that I went to a corner to really cry. And so he finally, so the next time he asked me, how are my parents? I told him they're fine and they've said hello to you. And that became the joke now. As he was now finalizing his days here on earth, he went into coma so many times. And when he went into a coma, the last one, I realized I had carried a lot of pain and I hadn't dealt with it. And so I told him, Dad, because he wasn't talking by then. So I went into hospital and I told him, Dad, I feel we need to make things right because I've been angry at you for very long, because he had broken my hand in the process, feeling angry at me, thinking I've taken over his family. In fact, one day he told me, who told me that I can usurp authority over his family? So he felt like I was taking over his life, which also I had, because I didn't understand what dementia was. If it was now, I think I would have done things very differently. I would have done things with him and not for him. And so the mistakes I did, I have learned, and that is what I'm trying to help other caregivers not to make the same mistakes. And so I had an opportunity to just shake hands with him and tell him, Dad, I just held his hand and told him, I want to say sorry. I may not have treated you very well. And please, could you forgive me? And I felt like I couldn't understand why of all the children, it's I who you forgot. And so he just squeezed my hand. And for me, that was amazing, because I was able to deal with the loss after he rested. But one thing that I noticed with him, and which is very encouraging, was whatever they had learned as like their religion, that never goes away. I have been to see families, even Indians, for example, and they'll still pray to their God. They remember all these things. And then one of the things we tell people is also to have a schedule. For example, if they're supposed to eat by 12, make sure the food is there at 12, because they will not remember to look at their clock. But when you have a system in place, when it reaches 12 o'clock, they know it is time for them to eat. So having a system also helps them become calmer and they are less agitated. And so we had a service just a few weeks before he rested, and we did a song. My dad was from the Kamba community, and so we did a song, and we sang it in Kamba. And one of the things that was amazing, my dad was already on a wheelchair. He was using oxygen to breathe. He couldn't breathe on his own, and he lightened up, and you could see his eyes and everything, and he started moving his hands, sat up on the wheelchair, because when we came in, he was slumped on the wheelchair, and he started singing along. And within a few seconds, as the song continued, and towards the end of the song, as it continued, he kept slumping, and finally, when the song ended, he was back to his slumped position. So singing makes a difference. Songs that they can identify with makes a difference, but it is all not gloom. I mean, there's joys, there are moments of happiness, as much as dementia can be a very stressful disease. And so one of the things we tell the caregivers is to make sure that they check on their mental health, talk to people. Depression is rife because you are so alone. People don't come visiting you. Like us, our home was deserted. People never used to visit us. And that's the story with very many caregivers. So let's be different. If we know there's a family member or a friend who has a loved one with dementia, let's go and visit them. Give them time to go breathe, and then they can come and continue taking care of them, which is also ties up to social isolation. That also is rife. A lot of people they don't understand what you're going through, so they prefer to stay away. And then there's a lot of financial burden. Dementia is a very costly disease, because they not only have dementia, they have other conditions. They have blood pressure, they could be having diabetes, they could be having pneumonia. So there are very many things. So they're always in and out of hospital. When they come to the stage of diapers, when you have to have caregivers who are taking care of them. And then the psychological health, that needs to be also checked, both for the caregivers and the people living with dementia also. Sometimes they are so stressed out, like Dad would reach a point and he's just tearing up. So let's just make sure that we give them the best life. How you would want to be treated. Yes, there's no cure for dementia, but love will work for them. When they know that you love them, once in a while we've had caregivers saying, they always say thank you for being taken care of. Then because of what you're going through, sometimes as a caregiver, you neglect yourself. Take time to care for yourself. And I think that is where I want to stop. I want to say thank you for the opportunity to share my story. Santeni.
Thank you very, very much, Elizabeth, for sharing that story. Like I said earlier on, you actually are an inspiration to many. And I can say it because you are an inspiration to me for what you did, how you had taken care of your father, and feeling very lonely and lost because nobody was talking about dementia in is it 2019? Or did you say 2007 or 8? Only dementia has just become really very, very recently one of the focus areas for mental health in Kenya. We know that mental health has always been neglected. Different types of issues in mental health have always been neglected, but now we are realizing that we need to embrace mental health as one of the common, there's a major common, it's not one disease, there are many diseases, but something that we need to address through our Ministry of Health, our policy levels, training, education, training and education of healthcare workers, people living in the community, creating awareness, and ensuring that people understand how to support people with dementia, can make a diagnosis and then refer them appropriately. I remember again, when you had the conference some time back, one of the participants, a young girl, was taking care of her mother, was told by a very senior doctor that your mother is a mad woman, take her to Mathare, yet she had dementia. So there is a lot that we need to learn, even as healthcare providers, and also the public, so that we can support people who are going through this kind of an illness. It can be a lonely place for that patient. It can be a very difficult place for the family members. So we have a lot of comments for the two presentations. People are impressed with the presentations. They have learned a lot and many other things. But I would like, maybe just because we have we already we're not behind time, but we don't have much time. I'd like us maybe to just focus on the Q&A section for now. So I'll just ask some of these questions, and some of them are addressed, but not particularly to anybody, but for the two speakers. One is, some people say dementia is due to being too active, that is exhausting your brain. Christine, maybe you'll respond to that. The second one also is talking about compromising brain functioning. Kristen, can you respond to that? Those two issues on brain dysfunction or too much functioning?
Yes, thank you, Dr. Zipporah, and thank you, Elizabeth, for sharing that story. I think I'll combine that into one statement, that dementia is due to active. I'm trying to look at the comment, but you talked about is due to, overly use of the brain. Some people that, I've seen that, dementia is due to being too active, exhausting your brain. And I think these were the conversations that we had started when I asked the team, what do people say dementia is? So I think we've already discussed about that, discussed on, in terms of what dementia is, what are the causes, and rather it is not their own fault. It's because of our brain, a specific either reversible or irreversible causes.
Okay, thank you. Just maybe again to add on that one, somebody has asked a question that what in Kenya has been found to be a great cause of dementia. Maybe from your study, is there anything that you addressed in terms of causes, or where is it particularly more prominent in which parts of the community in Kenya?
Yeah.
And somebody else, the same person is asking, how can we prevent it and how can one assess risks?
Wow, this is a huge topic, Ruth, which cannot be delivered in a sentence, but I will say the greatest risk factor is age, which I said doubles after the age of 65, tends to double, the prevalence tends to double after the age of 65. But some of the risk factors that I talked about are the ones, the reversible causes. Those are risk factors as well as causes, because if you're able to see that someone is having depression, or someone has an injury or brain trauma, so if you are not able to address these, mental health conditions or physical conditions that can affect the brain, then this can result into dementia, which is irreversible. So one of the things is to try and manage our lifestyle, because this is an aging population, and also try and see how we can prevent dementia in the long term by trying to address the causes in terms of the conditions that I just mentioned about, the several conditions, and you can read more on the exact, most risk factors, not just in Kenya, but across the globe, because we are a population that exists, on earth, and the factors that we face are similar to other countries. And so even, if it's substance abuse, then other countries will still experience substance abuse, will also experience substance abuse. So addressing some of these risk factors can be a great thing in terms of prevention. So there are a number of risks. There's no single cause, but it's a multiple myriad of causes that we can be able to prevent in order to address dementia.
Thank you. There's another question also where somebody's sharing that they had a 52-year-old patient recently who developed sudden onset of stammering 2 years ago. Over the time, she has been noted to be forgetful, but not significant enough to cause concern. Investigations and images are normal. Please help. Could this be dementia in early stages?
Thank you, Joseph, for saying that. We cannot say specifically that it is dementia, because there are other conditions that really present like dementia. You could have someone stammering, but they have a different condition, maybe onset of stammering, but you can't say it is dementia until you have ruled out other conditions that, you know, have you checked if it is other, you know, if someone is forgetting, have you checked causes of, you know, if someone has vitamin B12, have you checked other, you know, mental illnesses? Because one of the DSM-5 criteria, the second or that 3 says you need to rule out other mental health conditions so that you can actually confirm that it is dementia, but it also needs to have a specific diagnosis in a more, maybe, I don't know which hospital you went, but there are a number of hospitals that can actually tell the type of dementia when it comes to a specific, you know, scan.
Okay. Thank you very much. So somebody else is sharing about her mother having dementia and they want to be supported. I think they've asked for the telephone numbers and I've seen them being responded to. Somebody also is talking about a community member says she can relate to people with dementia because it's not their fault. Healthcare workers need to treat their patients equally, regardless of fault. You cannot refuse to treat because who crashed, I can't think something is missing there. Those who crash their car when drunk, smokers who develop throat cancer and so on. And we have seen stigma against those with HIV early in that pandemic. Cannot refuse to treat COVID-19 patients who refuse vaccination and do not mask. So I guess just a comment that we need to be able to identify issues and treat them appropriately, maybe even early identification, because that's very important. Joseph is talking about what is the response of care guard once a patient is started on it. And then can high intake of salt increase or worsen dementia? Can it affect children? Yeah.
Yes, I'm going to leave the surrogate aspect for a more clinical aspect, or maybe Dr. Zipporah, you could respond to that. But in terms of intake of salt, I think this is more in terms of, because hypertension is still a risk factor, then it's possible that once you have hypertension, then you're encouraged not to reduce your salt intake. So most of the time, it's not usually the salt, but actually when you have a diagnosis and then, you know, the intake worsens the condition or becomes a risk factor. So we really can't say that intake of salt can worsen dementia, but it can be a risk factor, and especially when you have hypertension. So it's important to moderate, and it's basically everything, not just salt. High intake, you know, can be anything and not just salt. So if you moderate, you know, things that we are taking, even oil, even, you know, because it can lead to obesity. So there is addressing the risk factors on moderating the intake of, you know, food and other related ingredients, and that can help contribute in terms of addressing the lifestyles that can contribute to developing dementia.
Thank you. And somebody has asked, can it affect children?
Can it affect children? Sometimes, most of the time when you, most of the time it happens among adults. For dementia, it will be the specific conditions that affect children that will present in a certain way. In children, when you have, for example, ADHD, attention deficit hyperactivity disorder, it can have some aspects or a characteristic symptom or characteristic behavior that can relate to adults, but it doesn't mean that someone has dementia. Most of the time it affects adults rather than children, but some of the symptoms can be similar to those in adults.
Thank you. And somebody else, I don't think that has really just talked about being.
Sorry,
Okay,
Dr. Zipi, before you move to the next question, I also wanted to point out, I know a lot of us are thinking that only people who are at 65 years and above are the ones who are getting dementia. We are getting a lot of people in their early 40s getting dementia. And also, but it is not happening in Kenya. Out of the, in America, we have seen cases of actually children having dementia, but it is another form of dementia, but it has the same symptoms that you would see with somebody having dementia.
Yeah, maybe just to add on that, because somebody asked, is dementia, I think, I can't remember the question, is just one disease, or can you break up into many diseases? Dementia is the umbrella one. There are many other causes, many other conditions that come under dementia. So it's not necessarily that everybody, you can't classify everybody as having dementia as one disease, but there are different types of things that come under dementia. So because this is, maybe we can look at that in the next topic. Somebody also wanted to is asking about the mixture of medications. I would like to understand about the mixture of medications, but I'm seeing that we'll probably not be able to do this. And somebody has also talked about, do supplements help in improving dementia, for example, omega-3? Could it be a thyroid function dysfunction? Could that be also the reason for a 22-year-old who has dementia? Yeah, some of the questions.
Okay, Elizabeth, would you like to address that? Continue, or I address the omega-3?
Just start on the omega-3.
Okay, so I'm trying to, are you able to, I'm looking for it. So do supplements help in improving dementia like omega-3? Scientifically, we have supplements that can contribute to improving some aspects in terms of cognitive function. Just like the way you would have, a certain supplement improving your cells or tissues, we can't say it can entirely help you improve dementia in, completely, but it can help some of the tissues or some of the cells in the body in terms of focusing on how they can work better. But it's not really actually treatment, but rather something that can boost your immunity.
Okay, thank you.
Sorry, what was the other question that had been asked? I'm trying to look for it. Sorry?
Somebody asked about, a thyroid function dysfunction, problems with the thyroid function. Can it be part of of the causes? But I also see, Elizabeth, many people have asked for your number because there are people on this session who have family members that probably have got dementia, some form of dementia, and they're asking for your contacts for adults so that they can maybe join the support groups. So please share those contacts. And I think because we probably I'm trying to see if there's anything you haven't responded. Is early dementia prevalent in Down syndrome populations? Is the other question. And the other one is there's an issue of what exactly is the treatment, but I guess we could actually have a session where you can focus on clinical treatment later on, not today, because it's not something that you speak on in just 15 minutes or less time. Yes, you're saying something, Elizabeth?
Yeah, I'm saying I think that is also the next time. I think we will also bring a neurologist on board so that also they can help, because like the medications and everything, it would be best if they can speak on that. So I've seen somebody asking what are some of the triggers of dementia. So a lot of times with the people who we work with, stress has also been a great contributor, other than the other factors that Christine has talked about. Stress, like loss of a loved one, loss of a job, loss of money. Some people do not know how to handle their stresses, and this has led to their downward, to them getting dementia. So stress also is a contributor, and it's still yet to be, of course, confirmed through research. But a lot of people, when they speak, you'll hear, when my father died, we started noticing the changes in my mom, or something like that. Number two, you've asked for my number. The organization is Alzheimer's and Dementia Organization Kenya. I will give you my phone number, but we have the office number. I don't know it offhand. My number is 0723 471 096. Again, 0723 471 096. So if you get in touch with me, then I can put you in touch with the lady who does the visits and the home visits, and the one who takes care of such issues in the organization. Thank you.
Great. I can also respond to the aspect on prevalence of dementia in Down syndrome populations. It has not been confirmed in Kenya because most of there's limited research on dementia, but from evidence populations in other countries or in developed countries, we have the National Down Syndrome Association that is based in the UK, and most of the people that are in their late, just like people that have no dementia or people that have no Down syndrome, they tend to develop dementia. Dementia prevalence tends to double after the age of 65. So in populations where people have Down syndrome, it also tends to be higher in older populations, 50 years or 60 years, it tends to be higher. And you'll find that it's about 50% or more and out there, between 30 to 50% of people who have Down syndrome will tend to develop dementia. But that does not mean that everyone who has Down syndrome will have dementia.
All right, thank you so much to panelists. I think we'll round out now. Thank you so much for the presentations, for enlightening us on dementia. We had a very big participation of over 900 people. That's great. But this is just also showing us that we will need to maybe now specifically focus on certain types of dementia and treatment, the clinical aspects of it, maybe in our next sessions. This was just for us to understand what dementia is, and also able to understand what our patients are going through and their family members in terms of people not understanding what it is and the myths and misconceptions surrounding dementia. So thank you very much, Dr. Musimi, and thank you very much, Elizabeth, for sharing your personal story. I would like to thank the participants. We have had so many people, like I said. I really thank you for staying on until the end. And I'd like now to ask Agnes, if it's possible from KNH to conclude for us and then announce the next sessions for the different, I think the next sessions for next week. But at the same time, Agnes, there's a question that people have asked that I'm giving it to you as well, is how can they get CPD points? Maybe you can mention that as well. Thank you.
Thank you very much. Thank you. We really thank you, our presenters, for this very informative session, and we cannot thank you enough. It is very timely, as you have seen from the comments, and thank you, our participants, for staying with us all through. For the CPD points, we'll have a slide that shows how we'll be able to get them, but for in case of any queries, you can email us at knhcpd@gmail.com. I know for some cadres, you've not been able to get them directly to your email, like for the clinical officers, but we have the registers which we give to the council, and they said they'll be able to issue the CPDs in time. Yes. So for our next sessions, we can see on our screen, we have next week, we have on Tuesday, we have a TB series that is ongoing. And we also have on Thursday, we are preparing for EMTCT. It will be the World Hepatitis Day in EMTCT series. And we welcome you to join us during those times. We'll have the sessions, today's sessions recorded, so we'll be able to get the recordings if you require them. And here is information about the CPD. So we have come to the end of the session. Many thanks once again to Dr. Zipporah Ali for taking us through this session. Thank you, Elizabeth Mutunga, for sharing your story. And thank you so much, our keynote speaker, Dr. Christine Musimi, for all that information. And also Professor Ndekei, we really want to thank you so much for allowing us to have this session and for your contribution to this. So we have come to the end. Have a lovely evening. Goodbye.
Thank you, and goodbye, everyone.
Thank you. Bye-bye.
Thank you too. Goodbye.